Good morning, and I'd like to thank the Society for the opportunity to present our work regarding volume and outcome relationships in bariatric surgery in the laparoscopic era. Which one? Okay. We do not have any disclosures, sorry. Volume and outcome relationship is well established. However, data was obtained before the wide adoption of laparoscopic bariatric surgery and was mainly observed for stapling procedures. Currently, centers of excellence are defined as hospitals performing greater than 125 cases per year by both the American Society for Metabolic and Bariatric Surgery and the American College of Surgeons. Metabolic and Bariatric Surgery Accreditation Quality Improvement Program was recently established as a quality program between the two organizations with a suggestion of annual hospital of 50 stapling cases per year. This is based on prior studies which demonstrated that observed to expected in-hospital mortality ratio was significantly higher at hospitals that were performing less than 50 cases per year, as depicted by the bar graph on your left, compared to those that were performing 50 to 100 cases per year, or those that were performing greater than or equal cases per year. Therefore, we aim to study the most contemporary data after the implementation of the national coverage decision in the laparoscopic era. Our primary objective was to analyze outcomes according to annual hospital volume threshold of 50 cases, defining high-volume centers as those that are performing greater than 50 laparoscopic stapling bariatric cases per year, and low-volume centers as those that are performing less than or equal to 50 cases per year, with a secondary objective to analyze the impact of accreditation at high-volume centers. Accreditation is based on designation by CMS. We use the nationwide inpatient sample, which is the largest all-payer inpatient care database in the United States, and contains information from nearly 8 million hospital stays each year across the country. It approximates a 20% stratified sample of the US. We sampled all patients with morbid obesity who underwent elective laparoscopic stapling bariatric procedures, specifically laparoscopic gastric bypass and sleeve gastrectomy as designated by the codes during the years of 2006 to 2010. We calculated risk-adjusted outcomes for our volume analysis with the primary endpoint of serious morbidity and in-hospital mortality. We also, within the high-volume centers, we also calculated risk-adjusted outcomes between accredited and non-accredited centers. We performed a logistic regression analysis, and Holmes' method was used to account for multiple comparisons to calculate the adjusted p-value. With regards to distribution of bariatric centers according to volume, we observed greater than 277,000 cases performed during the 5-year period, of which the majority of cases were performed at high-volume stapling centers, approximately 85%, and these were performed at a mean of 328 centers per year. Low-volume stapling centers performed 15% of the cases at a mean of 484 centers per year. High-volume stapling centers perform an average of 143 stapling procedures per year, compared to 17 at low-volume centers. 91% of the hospitals at high-volume stapling centers were designated as centers of excellence, compared to 55% at low-volume stapling centers. With regards to patient demographics, when comparing low-volume centers to high-volume stapling centers, we found that patients at high-volume centers were more likely to be African American, and they were more likely to be teaching hospitals at an urban center. With regards to patient comorbidities, we found that patients at high-volume centers had a higher rate of comorbid conditions, specifically pulmonary disease, diabetes, and hypertension. With regards to postoperative outcomes, we found a higher rate of anastomotic leak and septic complications at low-volume centers compared to high-volume stapling centers, a higher rate of wound complication in ileus, and a higher rate of respiratory complications at low volume centers compared to high volume centers. Overall morbidity was also higher at low volume stapling centers compared to high volume. And in fact, in-hospital mortality was approximately twofold higher at low volume centers compared to high volume. Mean total charge was also higher at $43,000 compared to $37,000. When we calculated risk-adjusted outcomes using high-volume stapling centers as a reference, we found a higher serious complication rate with an odds ratio of 1.2 and a higher in-hospital mortality rate with a odds ratio of 2.5 associated with low-volume centers. Within our subset analysis of high-volume centers, we analyzed outcomes according to accreditation. The majority of cases at high-volume stapling centers are performed as centers of excellence, approximately 91%. And with regards to patient comorbidities, when we compared non-accredited centers to accredited centers, we found that patients at accredited centers had a higher rate of comorbid conditions, specifically pulmonary disease, diabetes, and hypertension. With regards to postoperative outcomes, we found a higher rate of anastomotic leak rates at accredited centers, a higher rate of ileus and urinary retention at accredited centers. And overall morbidity was higher at accredited centers compared to non-accredited centers. However, in-hospital mortality was approximately 3.5-fold lower at accredited centers compared to the non-accredited centers. When we calculated risk-adjusted outcomes using accredited centers as a reference, we found a lower serious complication rate with an odds ratio of 0.84 associated with non-accredited centers. However, in-hospital mortality was higher with an odds ratio of 3.57 associated with non-accredited centers. Our study has certain limitations. There may have been errors in coding of complications based on abstract review. The NIS database is restricted to in-hospital mortality and morbidity, and we do not have information on follow-up, surgeon volume, hospital structural processes, or specific body mass indexes. In summary, compared to high-volume centers, low-volume centers, again, these are centers that are performing less than or equal to 50 laparoscopic bariatric surgery cases per year, had an associated higher risk-adjusted in-hospital serious morbidity and mortality. Within high-volume centers, centers without accreditation had a lower in-hospital serious morbidity. However, they had an associated higher in-hospital mortality. In conclusion, centers performing at an annual threshold volume of 50 stapling cases have improved outcomes. Non-accredited centers that perform greater than 50 cases per year had outcomes equivalent to that of low-volume stapling centers. And our data demonstrates that accreditation may have a greater impact on outcome than volume alone. Thank you for the privilege of the podium.
Thank you. Questions from the audience? Yes, Pascal.
I guess I drank a lot of coffee this morning, but I find it very interesting the dissociation that you see in non-accredited centers between morbidity and mortality, which intuitively doesn't make sense. And we see the same thing in our general surgery population with NISQUIT data, and I wonder if you've thought about it, and maybe there's an issue in terms of systemic response, systems in your hospital, in these hospitals to respond to sort of deathly problems versus morbidity being a completely different, in a different category. Have you thought about that and looked at how these hospitals have pre-rounding systems, how their emergency response compared to the accredited hospitals is organized?
Yes, thank you for your question. And that is a very great point, is that unfortunately, given the limitations of NIS, we do not have information on the structural processes at these hospitals. However, we do hypothesize that the patients who have complications at these hospitals are more likely to succumb to mortality compared to those at accredited centers.
Donna, Kevin Revis, the Oregon Clinic. Excellent work as always. Back over here. Excellent work as always. I just wanted to comment, and that is, I think one of the messages I hope you include in your discussion along the lines of a rising tide raises all boats, as you demonstrated not only the data that centers of excellence perform even better than high volume centers of excellence perform even better than the low volume centers. The complication mortality rate associated with bariatric surgery in this day and age is just outstanding, and it continues to improve and improve. And you can see the numbers that you demonstrated are now lower than that associated with many common general surgical procedures. And I think credit simply needs to go to the overall societies that are working to establish this type of centers of excellence, data collection and such, as you demonstrated here. So not only splitting it into high volume centers of excellence doing even better, but again, all groups seem to be improving as time goes on.
Jerry Larson,
Yes.
quick question, please.
Larson from Louisville. I would echo that previous sentiment. I was struck that the difference in mortality and the leak rate, for example, between the high volume and the low volume was very slight. Also, the ultimate mortality rates were not much difference, 0.07 versus 0.17, and perhaps it is because the higher risk patient, it would be more significant if you consider that your patients with greater comorbidities tended to go to the high volume centers, if you could somehow weight that in. You might respond to that. And then my second question is, in the low volume centers, 53% of them were centers of excellence. How can you be a center of excellence if you only do 17 cases a year? I thought that was a criterion for receiving that stamp of approval. Thank you.
So in regards to your first question, we did risk adjust our mortality rates, and there was a 2.5 increased odds ratio with regards to high volume centers. As in regards to your second question, that is a very excellent point, and the reason is because our criteria for low volume centers included only laparoscopic stapling procedures. Therefore, the number may be skewed secondary to the number of laparoscopic gastric banding procedures that are performed at those hospitals that we excluded.
Thank you very much.